Good evening, everyone. Welcome back to another Epilepsy Foundation Facebook Live. And tonight we are going to be talking about neuromodulation in the treatment of medication-resistant epilepsy. And I am thrilled to be joined tonight by two phenomenal women, Dr. Kathryn Davis and Dr. Sudha Kessler. And they are going to talk us through some of the most common questions about neuromodulation as a treatment for those who are not responding to medications in the treatment of epilepsy. So first, I'm going to introduce Dr. Kessler. Dr. Kessler is a pediatric neurologist in the Division of Neurology, and she has worked at the Children's Hospital of Philadelphia for quite some time. We are very happy to celebrate her recent promotion to associate professor in that department. So Dr. Kessler has expertise in pediatric epilepsy, in EEGs, in epilepsy surgery, and in the ketogenic diet. So welcome, Dr. Kessler. You'll be our pediatric expert for tonight. I also am thrilled to have Kathryn Davis, who is assistant professor of neurology at the University of Pennsylvania. And she's also the medical director of the epilepsy monitoring unit there and the epilepsy surgical program at the University of Pennsylvania. So she is the Associate Director of the Center for Neuroengineering and Therapeutics, and she's the Assistant Director of the Penn Epilepsy Center. So we are blessed to have an adult expert in Dr. Davis and a pediatric expert in Dr. Kessler, and we're going to be talking about neuromodulation. I also want to thank our sponsors for tonight's program for helping us raise awareness about neuromodulation as a potential therapeutic option for folks. And those sponsors are LivaNova, Medtronic, and NeuroPace. So we want to thank them very much for the opportunity to share this information with you. So tonight I want to start with what is neuromodulation? There may be some folks in the audience who have not even heard of that term or know that that's an option for treating epilepsy. And I'll open it up to both of you to comment. What's neuromodulation?
Well, I can begin by saying that when we think about epilepsy therapies in general, I always think about four categories: medications, surgery, devices, and diets. And what we're really talking about today is devices. So, the brain cells talk to each other with chemical signals, but also with electrical signals. And you can modulate or change the way those signals work over time by using devices to provide electrical signals coming from somewhere else besides your brain.
So in a way, it's changing some of the electrical patterns in the brain, exactly right, if you will. Okay, great. So how are neuromodulation treatments given? When you say devices, where do the devices reside? How do they work? Dr. Davis, let's start with you.
Sure. So there are three main devices currently approved in the United States for epilepsy patients, and each of them works a little bit differently. So the first device that was made available is the vagal nerve stimulator, and that is actually not implanted inside the brain, but there's stimulation of a nerve in the neck called the vagus nerve, and then the actual computer or computational part of that device is implanted in the chest wall near where a pacemaker would be, which a lot of people are familiar with. Mm-hmm. And then the next device that was approved was the NeuroPace responsive neurostimulator system. And that device, there are electrodes that can deliver this stimulation that Dr. Kessler was talking about that are implanted permanently in the areas of the brain where the seizures are coming from. And then a computer part of that device is actually implanted in the skull, and then that device can trigger stimulation through those electrodes when it sees rhythms that are associated with potential seizures. And then the last device that was the most recently approved device in the United States is the deep brain stimulator, and that's been used for years in another neurologic condition, Parkinson's disease. But in this case, we're targeting a seizure hotspot in the brain, which is part of the thalamus. And so the electrode leads are targeted there inside the brain. And the computer part of the device, again, is in the chest wall. It's tunneled down there from the head. Similarly, it can then deliver stimulation to those leads in the thalamus.
Great, thanks. So I heard you mention 3 different types. So VNS, RNS, and DBS, right?
Yeah, a lot of different letters.
Yeah, all of them related to stimulation as the S part at the end. And I want to share with folks in the audience that if you'd like to get some more information or want to do some more reading about each of these different options, you can find that on epilepsy.com/treatments. There's a nice website that can take you through some of those specifics again. But first, let's talk about who might be a candidate for these kinds of treatments. Somebody, either a child or an adult who has medication-resistant epilepsy. What does that mean? What is medication-resistant epilepsy?
So treatment-resistant or medication-resistant epilepsy is what we call epilepsy when a patient has tried 2 medications that are appropriate for their type of epilepsy and that have been tried at optimal doses, and seizures persist even with trials of 2 appropriately chosen medications. And the reason that we think about, we call it that at that stage, is that we know that while the majority of patients will, or about half of patients will respond to the first medication, meaning they'll stop having seizures with 1 medication. A much smaller proportion stop having seizures after a second trial, and an even smaller proportion become seizure-free with each subsequent, with every the 3rd, 4th, and 5th medication tried. And so we know that at that point, the chances of becoming seizure-free with medication treatment alone, whether you're using medications in combination or just trying one after the other, in either of those circumstances, it just becomes less likely for a patient to become seizure-free. So then we start thinking about what are the other options, and the other options really depend on what kind of epilepsy, the characteristics of the seizures, sometimes the age of the patient, and a host of other clinical factors. So to decide on what next therapy, it's really best to work with an epilepsy specialist who can tease out those different factors and recommend appropriate testing that needs to happen in order to decide if your child, or if you're an adult with epilepsy, are appropriate to have epilepsy surgery or to have a device or another treatment.
That's great. Thank you, Dr. Kessler. So what I heard you say is if you've had epilepsy, you've had seizures, you've been treated with medication, and you've tried at least 2, but they haven't worked to control the seizures completely, you're not completely seizure-free, that's really the point at which you need to start thinking about other options. And those other options can include multiple different approaches. Neuromodulation is one of those approaches. All right. And Dr. Davis, is that the same is true for adults and for children? Is it the same definition?
Yes, it is. And we now have multiple different studies that have replicated what Dr. Kessler described, where unfortunately with additional medication trials, despite us having more and more seizure medicines available, that there's less and less chance that a patient will become seizure-free. So it's the same recommendation. Once a patient has tried appropriately chosen medications, at least 2 of them at good doses, we really need to start talking about other therapeutic options, including various surgical options, inclusive of devices.
Right. So once you have reached that sort of medication-resistant status, you really need to be coming to probably an epilepsy center or an epilepsy specialist to be able to talk about those more advanced treatment options, right?
Right. Yes, definitely. So, I think, sorry, Brandy. So to add to that, that's actually, I think, recommendation from our major society, the American Academy of Neurology, that patients that are still having seizures that have tried 2 or more medications should see an epilepsy specialist at least once every 2 years to see what other options there may be for that patient.
Yeah, that's very important. And I think not enough people know that. So I'm glad to get that word out. So if someone is considering neuromodulation and having a device implanted, what kinds of outcomes can they hope to achieve with neuromodulation? And Dr. Davis, let's start with you and then move to the pediatric situation with Dr. Kessler.
Sure. So when considering neuromodulation, it's usually after it should be after discussion about whether a patient is an ideal surgical candidate for a potential surgical cure. So neuromodulation is used as what we would call a palliative device, or palliative options, which means that it has a chance to substantially improve seizures, but the expectation isn't that the device alone would make a patient seizure free. And also the expectation is that patients with devices like the 3 devices we're talking about today may be able to decrease the total amount of seizure medicines that they're on, but not come off of the seizure medication. So it's important to know that those are the expectations, that you'll still stay on seizure medicines, but that we can have a really good chance of substantially reducing the number of seizures, and in doing so, improve patients' quality of life and also safety, and the risk of injury or death from epilepsy.
And for children, Dr. Kessler, what kind of outcomes can you expect for children?
How well the devices work is largely the same in children as in adults. Obviously, it's somewhat specific to each patient situation. Every child is unique when it comes to epilepsy, I find, but we can make decisions based on many things. And then one of those things I think is what the goals are, because as Dr. Davis was saying, sometimes though we want the goal to be no seizures, no side effects, and a life lived free of worry about epilepsy, sometimes we have to set different goals to help patients and their families lead the lives that they want to lead. For example, sometimes a patient may have infrequent seizures or frequent seizures, but the real problem is that they're leading them to have a lot of visits to an emergency room because they're prolonged seizures. Mm-hmm. And though we have home seizure rescue medicines to help with that, in cases where that doesn't work, we sometimes think about devices as well, because if we can use a different way of stopping a seizure from becoming a long seizure, then that can dramatically improve a child or adult's quality of life.
Absolutely. And, we've talked about 3 different devices, right? VNS, RNS, DBS. How do you make a decision about which is the right device for that person? Dr. Kessler, let's start with you.
Sure. Well, it depends on what sort of epilepsy. I would say that that's the key question. For us, that's the first question, and then age also plays a part, which I'll talk about in just a moment. So when we're evaluating a patient to understand whether they can have a surgery to get rid of their seizures, sometimes we encounter a situation where we either find that the seizures are coming from a part of the brain, which is really valuable real estate, meaning that removing that part of the brain to get rid of the seizures will also permanently affect them in a way that may not be worth it. For example, weakness of one arm, weakness on one side, or a loss of language. And so we wouldn't necessarily want to do that. And so we consider devices, for example, in that situation. Sometimes we encounter patients where seizures are coming from multiple places in the brain, or even 2 different sides in the brain, and there are limitations on how much brain you can remove, which is also somewhat dependent on the age of the patient. And so we also think about devices in that situation. sometimes we can't even tell where seizures are coming from because they're coming from many different places in the brain. And when there are many, many different hotspots, then we also consider devices.
Great. And Dr. Davis, we actually got a question from the audience that was asking, will you be discussing laser ablation? And I think it might be useful to talk about what is the difference between something like laser ablation and these neuromodulation devices that we're talking about.
Of course, that's a very good question. So laser ablation is a new surgical approach that has started to be used in epilepsy in about the last 5 years. And this is, laser ablation is considered when you're considering whether you could remove an area of the brain that could potentially cure a patient's seizures. So it's an alternative option to having a resective surgery where a part of the brain is removed. And so for certain types of epilepsy, particularly if there's a clear scar in an area of the brain, like the hippocampus, a laser ablation can be a very good option that your physician may discuss with you. But it's not functioning to modulate the brain networks like these devices that we're talking about. And the intent of that is typically with the idea that there's a high chance that we could cure the patient's seizures or stop the seizures from happening. So it doesn't fit into the neuromodulatory category, but it's an excellent treatment option to discuss with your physicians.
Yeah, so what I'm hearing is if your epilepsy is medication resistant, you want to figure out, are you a surgical candidate? And if you're a surgical candidate, you might be a candidate for either this approach to remove the part of the brain that is causing the seizures, this resective surgery or laser ablation, or you may be a candidate for neuromodulation, which would be without destroying brain tissue, you are implanting one of these devices to alter the electrical patterns in the brain. Does that sound right? It's kind of a medication resistant surgical candidate, and then what type of surgery would be most appropriate?
Exactly.
Mm-hmm.
Okay, great. Can you talk a little bit about some of the risks associated with any of the 3 neuromodulatory devices? Dr. Davis, we'll start with you. For adults, what are the risks that you talk about with your patients?
So I think it's important. There's certainly some common risks across all of the 3 devices, and it's something that it's important to talk to the neurosurgeon in detail about as well, because they may use slightly different approaches for the different device placements, and they would have different counseling related to the approach that they use. But the main, the devices overall are very low surgical risk. And the main risks are common with any type of surgical procedure, which would be minor blood loss and infection. And of course, the surgeons do everything to avoid both of those complications. Mm-hmm. For all of the devices, the rate of actually having to take out the device is very, very low, about 1 in 100 patients or maybe even a little bit less. So, so that just tells you how well tolerated these procedures are.
Mm-hmm. Dr. Kessler, risks that you discuss with parents and kids who are considering this?
It's largely the same as for adults. There's sometimes a little bit more counseling goes into the device, some specific things about the device. I'll just give you one example. For example, the VNS, which is the device that goes in to the chest here, the computer goes into the chest and is connected to a wire that connects to a nerve in the neck. Sometimes very active kids can do things that cause that wire to break. It doesn't happen often. I've had one patient that's happened to. He was trampolining, I think, and that's not a major issue, but that's a problem because then the device doesn't work, and the wire can be replaced. There are things that we can do to mitigate that, but you know, sometimes these things occur. The other thing is that the devices run on batteries. And so they do need to be, they have a, the battery has a lifespan, and they do need to be replaced periodically, which is particularly a concern because, you know, a child's life is expected to be much longer. So, and the time really depends on the device, the settings that you have the device on, meaning the more times the device gives stimulations, for example, can affect how long the battery lasts. Mm-hmm. So definitely good to discuss the specifics with your physician.
Great, great. So those are some of the risks of having the devices implanted. Can you both comment on the risks of having ongoing seizures? You know, if you choose not to pursue a new therapy, what's the risk of continuing to have those ongoing seizures?
That's a great question. And this is something that I know that Dr. Davis and I think about all the time and counsel our patients on. So, you know, for the patients that I take care of, learning, normal development can be affected by seizures. And that includes everything from academic learning to social and emotional learning, and learning to be in the world. And you know, ongoing seizures can not just be disruptive to the patient's life, the parent's life, the family's life, but it can also biologically affect those capabilities when they occur over a long period of time. So that's one of the big things that we worry about. Mm-hmm. And one of the other things that we worry about is an entity called sudden, unexplained, or unexpected. The U is sometimes used one way or another. Death in epilepsy, also known as SUDEP. And that is a worrisome occurrence where a patient who has epilepsy dies for reasons that aren't explained by an accident or drowning or having other causes of death like stroke or heart attack, and we just don't know. The risks and what puts you at risk for that is still something that's really actively being worked out. It's not really fully understood, but in adults with refractory epilepsy, that risk is as much as 1 in 1,000 patients with epilepsy. And so it's certainly one of the concerns that makes us want to do everything that we can to optimally treat seizures.
Absolutely. Yeah. So when people are considering, you know, this neuromodulation or surgery, they often focus only on the risks of that procedure, but really we ought to be balancing the risks of, you know, living with these ongoing seizures and the risks associated with the treatment. Dr. Davis, anything you want to add to that?
I think those were excellent points. I think we also, just to add to, we also worry with ongoing seizures that there can be progressive complaints of both memory and mood issues in our adult patients. And the risk of SUDEP is something that, you know, keeps every epilepsy specialist up at night, because we know in uncontrolled seizures, particularly convulsive seizures, and even more particularly if they're nighttime convulsive seizures, that is a real risk. And so when we're counseling our patients, we're weighing all of these different risks together. And you know, certainly in most patients that have drug-resistant epilepsy, the risk of ongoing seizures is far, far higher than any of these procedures, both the surgical resective type procedures and laser ablation and the neuromodulatory devices that we're talking about today.
Right, right. And I want to assure folks who are listening that if you want to get more information about any of these topics, about SUDEP, about neuromodulation therapies, medication therapies, dietary therapies, surgical approaches, you can find more of that on epilepsy.com, especially in our treatments categories. But we do want to emphasize that probably the best thing that you can do to reduce your risk of SUDEP is to continue to strive towards seizure control and getting the best possible seizure control that you can. As you mentioned, Dr. Kessler, it's a very active area of research, and we're finding new important discoveries every day that teach us hopefully how to help prevent this terrible outcome. I want to ask, for people, we got a great question from the audience that I want to share with you as well. For someone who's already had an epilepsy surgery that is a resection, right, that has maybe taken out part of the hippocampus or a particular seizure focus, but that didn't work to control their seizures, is neuromodulation an option for someone in that situation?
Absolutely. I have patients in just that situation. And I have patients who have had resective surgery, had one device, a VNS put in, and then when that didn't work, subsequently had an RNS, responsive neurostimulator, put in. And so none of these options are mutually exclusive. You're not choosing one or the other. You're often choosing what's next.
Mm-hmm. That's great news. Okay. I'm just waiting. I thought I was going to see another question from the audience come in, and they're so good that I want to highlight those if we can. So let's talk a little bit about how long does it take the system, once it's implanted, once it's modulating the circuitry in your brain, how long does it take to really start to have an effect on seizures if it's going to be successful for that person?
I can take that one to start. It is going to vary from patient to patient, but across all three devices, you really see your optimal response in the years long time frame. Really, at the 2-year time frame is where, from most of the studies, you see optimal response rates and see how far that patient is going to improve with the device. But you can see improvement certainly earlier on. Each of the devices have different types of programming schedules, and that also impacts how quickly patients will respond. And really encouragingly, with some of the now real world outcome studies that we're seeing, where the doctors have gotten better at programming devices, we're seeing earlier and higher rates of response to these neuromodulatory devices than in the initial trials.
Great. Yeah, if I'm remembering the data correctly, in the submissions for the FDA to approve these devices, there was a very clear, decrease in seizure frequency. But even after they stopped the blinded parts of the trials, that continued to go down. The longer term effect is pretty dramatic on these, and so people should be looking for a long term, landscape when they consider how long it will take to get to their very best seizure control with some of these devices.
I think that's an excellent point, and one that we should emphasize, which is that the way neuromodulation works to change the patterns of electrical activity in the brain is something that gets better and better over time. And I don't just mean months, but years and years, you'll continue to see a decline in seizure frequency.
Great. So folks should keep that in mind. We got a great question about side effects. Can you comment on some of the side effects? I've heard you can get a sore throat with the VNS. What kinds of side effects do you often hear from your patients?
I can start with that one, I think. For VNS, you're right that there can be a change in that throat area. And really, it's usually a hoarseness that patients will complain about when the device is going off. And the clinicians can often, we can often change the settings on the device to make that better. I have had some patients that are singers that you can also turn off the device when you're doing something really important to use your voice, like if you're a singer. So you can, you're given a magnet, you can tape it over the device and turn it off for when you're doing really important things if you do have that side effect. But it's usually quite minor for the VNS. And we can change the settings to deal with it. For the DBS and the RNS, the vast majority of patients have no stimulation-related side effects. There have been some RNS subjects that have been published in research studies where the doctors have actually taken advantage of some mild side effects with stimulation to tell the patient when to take a rescue medication. But for the vast majority of patients, there are no symptoms or side effects. And again, we can change the settings if there is something that happens so that you can't feel the stimulation.
I think that
was a question I was going to ask is, I know people are wondering, can you feel the stimulation?
That's a great question. I was just going to address that too. And you can't actually, because the brain itself doesn't have nerve receptors the way that our skin cells have, or other parts of our body has. And even with the vagus nerve stimulator, you can't feel the stimulation itself. What people feel is that the little tiny nerve that goes, there's a little tiny nerve that comes from this big vagus nerve and goes to your voice box, to your vocal cords. And it can send a signal to make your vocal cords tighten up. And that's why you feel that little hoarseness or a little clearing of the throat when the device is going off. In my experience, I haven't seen it that often in kids. It can happen at the beginning when you start to turn on stimulation and as you're going up on the settings. But then it's kind of like walking into a room and you smell a strong smell, but then after a little while, you don't really sense that anymore. You don't feel it anymore. It's sort of the same thing. You get used to it and you don't even know that it's going on or off.
Great. Another question we just got from the audience is, can you speak to CBD and neuromodulation? So are they compatible kinds of treatments? Is there any contraindication to using CBD if you're also have one of these neuromodulation devices implanted?
That's a great question. And there isn't, CBD, cannabidiol, is a medication, just like any other. And I know some people feel very differently about it because it comes from a plant. It is a molecule, it is a chemical, and it works in the brain like other seizure medications do, even though its specific way of acting is different than other seizure medicines. And just like we continue seizure medicines in patients with devices, CBD can be continued as well. I don't think that we know of any special combination power of them. I don't, or really with any specific medications and devices, but certainly they can be used together.
Great, thank you. Someone has asked, can you comment on implanting devices after a large section of brain has been removed? I know we did talk about they're not mutually exclusive, but does the size of the prior resection make a difference?
I can comment on that initially. So it depends on the device, certainly not for the VNS device, because as we talked about earlier, that's not a device implanted in the brain. For the DBS device, because the surgeon is trying to target this area of the brain called the thalamus, with certain types of resections, it can make the targeting a little bit more difficult. And so that can make it a more challenging surgery. And so that's something certainly that would be the surgeon would have to assess and see if he'd be a good candidate. And similarly for RNS placement, if you're trying to place the RNS leads right next to the surgical cavity, it can be also a challenge because you need to be able to, affix, like get it to stay in that area. And if there's been a lot of tissue removed, there might not be anything to keep it stuck there. So again, it may be a limiting factor, but that's pretty rare. And it's most often the case that patients are still candidates for one of the devices at least.
Okay, thank you. We got an excellent question, which is, someone has been told that they're not a candidate for a device because they have seizures that occur in all points of their brain. Is there a device that works for seizures that happen in multiple areas of the brain? Dr. Kessler, let's start with you.
Sure. So that is not a limiting factor. So the VNS can be used for seizures that arise from one part of the brain and another part of the brain and another part of the brain and another part of the brain, or what we call multifocal. That is not a barrier to having a VNS. Or a DBS, the deep brain stimulator, is for focal epilepsy, but it can also be used for folks who have seizures that come from many different places, including places that you're not even quite sure where they're arising. You don't need to know specifically. there are some people have seizures that we call generalized, or have epilepsy that we call generalized, which means that on EEG, on the brain tracings, it looks like the seizure arises everywhere at once. What we think is really happening in the brain is that it has more to do with these rhythms that go between a deep part of the brain called the thalamus and the rest of the brain. Those seizures sort of work in a different way than focal seizures. And for those seizures, you can a VNS is still used for those seizure types. At this time, DBS is not used for that, is not approved for that use. But I know that there is very active research in applying DBS in slightly different ways for patients with generalized epilepsy, and so things to think about and look forward to.
Yeah, so it sounds like the answer to that is if you have seizures that arise in multiple areas, it's not necessarily a no.
That's right.
That you should get some consultation and advice, preferably with an epilepsy specialist who would be able to work with you through those considerations. We got a great question. Can someone have both a VNS and an RNS? And is there a benefit to having more than one of these devices?
I can take that. So it's a great question. It is very common that patients will choose the neuromodulatory device VNS first, either because that was all that was available when they were deciding to get a device, or because it doesn't involve brain surgery. So it is a less invasive device. And you can still have multiple devices. This wasn't allowed in the clinical trial, but in clinical practice, including our practice, we have many patients that have both devices, and many of them have both of them turned on at the same time. So you can also be using both of the devices together. There's active research looking at how well that works together, but it certainly is not a problem, and it can be done.
You know, I'm gonna take the moderator's prerogative and ask a question that I've had about neuromodulatory devices, and that is, do we really understand how they're working? Which, I mean, is just fascinating to me. There's lots of medical interventions that we don't quite understand how they work, but they work, and so we use them. But here, I think it's just fascinating to try to understand, how do these devices actually change the circuitry in the brain so that seizures are less frequent? Any research on that or insight into the mechanisms? Dr. Kessler, anything in kids that we know about how VNS is working? Or
that's a great question. And I actually think it's one of those areas where we know less about how neuromodulatory devices work than, for example, how certain medications work, because studying that in model systems, meaning in not in actual people or actual patients, is pretty challenging. There's some, medications, for example, are often studied in animals. And so we understand a lot about the biology of them, but that's a lot more difficult to do with devices. But I think that there are things that we are starting to surmise or to sort of study in a little bit more of a distance or from an angle from the growing number of patients who have had these devices and how they work. I think that as we understand more sort of basic stuff about the brain, we'll also start to understand more about how they work, and more importantly, how to optimize how they work, because I think that there's a lot more to do there, not just inventing new devices, but honing the way that they work so that they work better.
Mm-hmm. Thanks. Dr. Davis, anything you want to add?
Yeah, and I think there's a lot of exciting work in this space, as Dr. Kessler pointed out. The initial work in at least brain stimulation that led to its approval really is related to patients that have undergone surgical evaluation and have electrodes placed in their brains to know where seizures are coming from. And when we do that, we do stimulation to see where important areas of the brain, like speech, are in that patient's brain, and also now there's work looking at how seizures may spread based upon upon stimulation. So I think that there's a lot to know here still, but there are many investigators, including some at our, myself and others at our institution, looking at how stimulation follows the underlying brain structure, and we increasingly think of epilepsy as a disease of networks in the brain, and so neuromodulation really fits into that relatively new line of thinking about epilepsy. So it's a really exciting time. And I also know there's a lot of work being done on how to optimize or pick the best settings for these devices for each individual patient. So I think in the next few years, we'll see a lot of advances in that space that are really brought to the bedside. So we're getting really close with some of that.
Yeah, it's really a frontier in neuroscience right now, is understanding how these work. We've gotten a couple more questions from the audience. I want to make sure we get a chance to answer these. There is a question about whether any one of these three devices is better for temporal lobe epilepsy. Dr. Davis, can you start with that question?
Sure, another great question. So none of these devices were compared to each other. I think that's really important to keep in mind. So when you talk to your doctors about what device is best for you, they will be taking the data from each of these studies and their clinical experience, and then the data that's coming out now for the real world experience for the devices, and trying to make the best recommendation for you. And in those studies, it does appear that DBS and RNS, the two devices that are inside the brain, work about as well as each other for temporal lobe epilepsy. But there are pluses and minuses to each of those devices that are very patient specific. For instance, one big plus that for some patients of the RNS system is that you are actually recording some of the brain data, and that can give us information about how well your brain is responding to a medication change, or what parts of the brain when you're on your medications are causing the seizures, and are there other things that we might be able to offer you based upon that longer term recordings of your brain waves. Whereas a big benefit of DBS is we don't need to know specifically where in your temporal lobe the seizures were coming from to know where to put those leads, because in temporal lobe epilepsy, the DBS will always be targeted at the same part of the thalamus. So there are a lot of subtleties here. So it's a discussion really to have with an epilepsy expert.
Great, and that's an excellent take-home message. Is the best answer is always talk to your doctor, seek out specialized care, and get the best advice for what will work best in your situation. We've gotten a question about, can seizures cause cognitive delays? And Dr. Kessler, I'm going to ask you to address that question first.
Yeah, that's a really complicated question when you really start to tease it apart. So, in children, we're not just thinking about sort of somebody's here, they start having seizures and they might have a loss of some functions, because children are growing and developing. So we're also talking about their developmental trajectory. And when you have something that sort of crashes into that, how does that affect it? But it's complicated because sometimes the underlying reason for the seizures can also affect development. For example, if you have seizures because you have a difference in the way an ion channel in your brain works. With the ion channels are little doors that let sodium or potassium or calcium or other ions in or out, and that's part of the way brain cells signal to each other. If there's a difference in the way that works, then it may lead to seizures, but it may also lead to differences in the way your brain works to do the things that we expect it to do, like think and talk and those kinds of things. And so teasing out seizures from the underlying cause can be difficult. We don't think that any one seizure can permanently affect your brain, except for long seizures that go on for hours and hours, but any one doesn't. But we know that people who have seizures that don't respond to treatments over years and years often do have a decline or a difference in the trajectory of their cognitive development.
That's another reason why getting that seizure control as quickly as possible is important.
That's exactly right. The earlier, the better. with children.
Right. Dr. Davis, in adults, can seizures cause cognitive decline?
Yeah, that's a very good question. Unfortunately, yes, definitely can see that as well. And in similar cases, as Dr. Kessler pointed out, with years of ongoing seizures, particularly from areas of the brain that are really important for memory, patients will frequently experience a decline in their memory. So again, intervening earlier can halt that decline. And in addition to all of the other things that are associated with seizures that we've been talking about today, like injury, et cetera, and also get patients with adult patients uniquely in comparison to pediatric patients, the epilepsy, when you have drug-resistant epilepsy, will frequently greatly impact your ability to have the job that you want, to live the life that you want, to drive. And all of those things that can be really critical to functioning at your highest potential in our world.
Absolutely. Yeah. And, we've been talking about the seizures, but we should probably also talk about some of the other comorbidities that we know many people with epilepsy experience, things like having depression or having anxiety, having memory issues. There are programs available for folks to help better manage their epilepsy. The Managing Epilepsy Well programs and self-management are one set of programs that can help people when they're struggling with those issues. And if you are listening and you'd like to get more information about that, you can always call the Epilepsy and Seizures Helpline. This is a 24/7 helpline that can answer your questions, point you to resources, get you connected to epilepsy specialty care. The number for the helpline is 1-800-332-1000. And you can call the helpline. They can help you in English or in Spanish. If you'd like to ask your questions in Spanish, the number is 1-866-748-8008. And again, they can help direct you to resources about any of the topics we talked about in this program tonight, or those Managing Epilepsy Well programs that can help better manage epilepsy. I did want to ask about after someone's had a neuromodulation procedure, how long is it until they can sort of return to their normal activities? If we're talking about an adult, Dr. Davis, how long should they expect to be either in the hospital or out of the hospital recovering and then back to normal activities?
Sure, another great question. So with a VNS, to start there, that's the simplest procedure. It's an outpatient procedure. So the patients don't require hospitalization. And typically the recovery period is quite quick. Depending upon the surgeon that places the device, they may put limitations on some of your physical activity, but in terms of returning to work, you'd expect to have a very short period measured in days that you may want to be absent from work, for instance. For the other two devices, they typically require 1 night in the hospital, so not a significant amount of time. And then again, surgeon dependent how long they tell you to avoid more strenuous activities, but for most patients, they can return to non-strenuous activities and their workplace or other types of typical activities within a few days. So it's not a long downtime. Okay,
and is that the same for children, Dr. Kessler?
Yes, children are remarkable at getting back to their normal lives, and spring right up often right after surgery. So the surgeons will often give parents specific instructions on what to do when, but kids even with the devices that go into the head like RNS, the stay is usually just a couple of days in the hospital and then home.
Great. We've gotten some questions. So Dr. Kessler, I'll ask you this one. Can these devices be used for LGS? So, and first, maybe you could explain what LGS is, and then are they appropriate for patients with LGS?
Sure, that's a great question. LGS stands for Lennox-Gastaut syndrome. What syndromes are in epilepsy, it's just a syndrome is the name we give to a cluster of features that are usually clinical, meaning what the seizures look like, what the age that the epilepsy started, and then often something about the EEG characteristics that those patients will have. And Lennox-Gastaut is a syndrome which is characterized by multiple seizure types, of which at least some of them are those seizures that I was calling generalized. And often it begins in childhood, and sometimes even begins with another kind of seizure syndrome in infancy called infantile spasms, and then evolves into this. It can have many different causes. You can have genetic causes, and differences in the way your brain was formed, injury to the brain. All of those things can end up leading to Lennox-Gastaut syndrome. And people with Lennox-Gastaut syndrome have intellectual disability or cognitive challenges. So can the devices be used for Lennox-Gastaut syndrome? So VNS certainly can be, and I think in our practice at least is frequently, we use that for Lennox-Gastaut syndrome. The RNS has not really been used for Lennox-Gastaut syndrome because the point of it is really to target seizures that come from one or two specific areas in the brain, and that's not really how LGS works for most patients, or it's just period. Actually, it's not really how LGS works. The DBS. So where the electrodes are put in the DBS as it is currently approved and used, we don't have great data on whether it really works for generalized seizures, but we do think that there's research going on now that if the electrodes are put in a different place, then they might actually work for the kinds of seizures that you see in LGS. So I think that that's an evolving story and maybe coming around the pike, but not yet.
Okay, so definitely one to watch if you're in the LGS community and interested in potentially pursuing these therapies.
That's
Great.
Right.
Someone asked, can this work for patients who get seizures in the brainstem? Dr. Davis, can you take that one?
So I think that maybe that question may be related to this kind of generalized type epilepsy that Dr. Kessler was describing. And not specific to actually a brainstem, what we call nucleus or region. So I think similar answer that there's research going on, and some patients are currently being implanted in a different part of the brain for these generalized seizure types with the DBS device. Really, any patient that has drug-resistant epilepsy is a candidate for a VNS device. And I would also just kind of add what Dr. Kessler said. In patients with syndromes such as Lennox-Gastaut syndrome, that in many cases we have a very challenging time making patients, getting patients to that seizure-free spot, and we're trying to manage to make sure them to optimize their quality of life, and adding more and more medications on often will really negatively impact quality of life. And so VNS as a neuromodulatory treatment in Lennox-Gastaut, but also in other types of epilepsy, is much more effective than adding yet another medication after you've tried two or more, and is not putting a chemical in your body that impacts every part of your body like our drugs do, because they don't specifically just go right to the brain, into the hot spot where the seizures are coming from. So you can avoid some of the common side effects with some of our seizure medicines and still get more seizure control with any of these devices. So many of our medications cause people to be sleepy or confused or dizzy or nauseous. And so it's really something that should be considered for many patients, I think, a lot earlier than it currently is considered.
Yeah, those are excellent points.
And I would just bring up really quickly that there are surgical options for Lennox-Gastaut syndrome too, depending on the type of seizures that are predominating and the cause of the underlying epilepsy. So again, just really worth seeking out specialty care.
Yeah, thank you. Another question, Dr. Kessler, will ask you this one. Do the devices prevent all seizures or just the convulsive type seizures?
That's a great question. They are not specific to convulsive seizures. They can, the VNS, for example, can prevent lots of different seizure types. The RNS, the responsive neurostimulator, can respond to seizures arising from a very small place before they even start to have symptoms. And so it's not just for convulsive seizures. Great question.
That's great, great. And another question is, this is a very interesting question. I would love for you, Dr. Davis, to explain the difference here. Are neuromodulation devices a type of rescue therapy? And I think many folks listening tonight may have just started hearing this rescue therapy term in the field, and we want to make sure everybody knows what a rescue therapy is. And then the question is, are these devices a rescue therapy?
Okay, I'll start with what a rescue therapy is. So a rescue therapy is, it could be a device, so we'll talk about that, or more commonly a drug. It may be a type of benzodiazepine like Ativan or lorazepam, or an extra dose of your own seizure medication that's taken when you have a warning that you're going to have a seizure, or if you've already had a seizure, to try to prevent clusters of seizures. And this has become more and more a hot topic because there are new rescue medications that have come out in the last year or so that are easier to use for patients, different nasal sprays, and for instance. So that's the classic definition of a rescue therapy. But with these devices, you can also have, you can use it as a type of rescue in that, for instance, for the VNS device, you're given a magnet that a patient can choose to wear as kind of like a watch, or a caregiver can have. And if a patient's having a seizure or has a warning, you can swipe that magnet across the device to get an extra stimulation. So that works for some patients. It doesn't work for other patients. So, and some patients' seizure types, you can't do that fast enough, or it's just not feasible, but it can sometimes be a rescue. But the primary reason to get a neuromodulatory device is not for a rescue therapy. And as we've been discussing tonight, this is really something that works over time to change the underlying brain networks. And so it takes some time to start working, and we need to just kind of, on a day-to-day basis, still be getting that stimulation in the brain to decrease the seizures.
Great. Thank you. So I know we're getting close to the end of our hour, and I want to thank our two guests, Dr. Kessler and Dr. Davis, for joining us and sharing their expertise. Your patients are very, very lucky to have you, and we are lucky that you choose to volunteer your time with us. Thank you. I also want to thank the sponsors who helped to make this session and many other of our awareness activities possible: LivaNova, Medtronic, and NeuroPace. And I also want to thank all of you for joining and your excellent questions, and for being part of this community, looking to keep learning, looking to find new ways to stop seizures, and for supporting the Epilepsy Foundation and our work to help improve lives of people with the epilepsies. So I want to thank you all and wish you good night. Take care.
Good night. Thank you for having us.